Welcome everyone. In this video we shall be talking about two of the most important biliary disorders, primary biliary cholangitis and primary sclerosing cholangitis. Okay. So moving on to the first question. A 48-year-old woman presents with fatigue and generalized pruritus. She has a past history of autoimmune thyroiditis and a diagnosis of PBC is suspected. Okay. Which of the following is the strongest risk factor for developing her condition? So the diagnosis of PBC or primary biliary cholangitis has been made, which is the strongest risk factor. Remember that smoking, female sex as well as obesity, all three of them are risk factors for PBC, but alcohol use is not. Among these three, female sex is the strongest risk factor. This is a factual statement. We need to remember. Female sex has the highest risk factor. The female to male ratio in PBC is 9:1, almost similar to that of SLE. Right. And remember that postmenopausal women are most commonly affected. Right. We can also see that she is a 48 years old lady over here. Right. And another important thing regarding smoking is a risk factor for PBC, but remember that smoking is protective for PSC, primary sclerosing cholangitis. This is an important difference between the two. Moving on to the next question. Which of the following autoantibodies are associated with PBC? Now, anti-mitochondrial antibody, AMA-M2, yes. Remember that this is the most specific antibody. This is the most specific antibody for PBC, and remember, it is directed against PDH-E2. Now we all know that PDH enzyme complex, that is pyruvate dehydrogenase enzyme complex, is made up of three enzymes. What are they? We have pyruvate dehydrogenase itself, then we got dihydrolipoyl transacetylase and dihydrolipoyl dehydrogenase. Among this, E2 is dihydrolipoyl transacetylase. Right. Now this AMA, anti-mitochondrial antibody, is directed against this particular enzyme of the PDH complex. So this is a true statement. This is a true option. Then ANA, anti-GP20 and anti-GP210 and anti-SP100, yes, they are also associated, especially they are positive in AMA negative PBC. These ANA positivity is seen in AMA negative PBCs, right? And remember that they are associated with a more aggressive course. They are associated with a more aggressive course of the disease. If we talk about P-ANCA, no, P-ANCA is not associated. P-ANCA is associated with PSC, primary sclerosing cholangitis. Now, besides these, it is also associated with ulcerative colitis. It is associated with microscopic polyangiitis and also associated with Sclerosing syndrome. Sclerosing syndrome. Okay. And anti-smooth muscle antibody, this is also not associated with PBC. Anti-smooth muscle antibody is associated with autoimmune hepatitis. Okay. So an answer over here becomes B. Okay. Moving on to the next question. A 42-year-old woman presents with intense pruritus, fatigue and hyperpigmentation. Lab shows isolated elevation of ALP. She is also on follow-up for osteopenia. What is the likely diagnosis? Now we have intense pruritus. Excuse me. It is a sign of, it is a symptom of cholestasis. Right. Now, isolated elevation of ALP is also a symptom of cholestasis. Hyperpigmentation usually is seen due to melanin deposition, and is seen in chronic cholestasis. Osteopenia is due to decreased or deficiency of fat soluble vitamins, especially vitamin D. Right. Now, everything over here suggests of a cholestatic disease. And with that information, we can easily rule out option C and D. In autoimmune hepatitis, we would get increase in liver enzymes, right? We won't get an isolated increase in ALP in autoimmune hepatitis. In Wilson's disease also can be ruled out. First of all, Wilson's disease is found in younger population, and moreover, the neurosymptoms would be positive and you would get neurological symptoms in Wilson's disease. Now, we need to differentiate between PBC and PSC. Now, with a given presentation, remember that fatigue is actually the most debilitating or the most common, right, most disabling symptom, clinical feature of PBC. Fatigue can also be seen in PSC, but it is the most disabling symptom of PSC. Now, with a given set of symptoms that have been present in the question, we cannot differentiate between PBC and PSC. Now, in order to differentiate, we need to look at the patient, right? She's a 42-year-old woman. Now, with a similar set of presentation, when both of them are given an option, if she is a woman, our answer would be PBC. If the patient is a male, then our answer would have been PSC. Always remember the fact that PBC, in PBC, females are affected much more than that of males, whereas in PSC, males are affected more than that of females. Okay. Now, in this question, we have to differentiate only on the basis of the gender predisposition, right? So our answer over here would be PBC, option A. Okay. Moving on to the next question. Which lab abnormality is most characteristic of PBC? We all know that PBC is a cholestatic disorder. Is a cholestatic disease. So we would get increase in ALP. We would get increase in GGT, right? High AST to ALT ratio? No, that's a false statement. High AST to ALT ratio is seen in alcoholic liver disease. Elevated ALP and GGT? Yes, they suggest us of a cholestatic disease. Reduced IgM levels? No, that's a false statement. Remember that PBC is associated with increased IgM levels. PBC is associated with increased IgM levels. And decreased bilirubin early in the disease? No, that's also a false statement. Remember that in early PBC, there is normal bilirubin. There is no change in bilirubin. But if we talk about a late disorder, late PBC, right, we would get decreased bilirubin, not increased. We would get increased bilirubin, my bad. We would get increased bilirubin, not decreased. Okay. Now this is due to progression. This is due to progression of the intrahepatic cholestasis. Right. Now, besides these clinical features, besides these lab findings, we also get in PBC, there is hypercholesterolemia. We get hypercholesterolemia. Right. Now, due to this hypercholesterolemia, we can get symptoms like xanthomas. We can get symptoms like xanthelasmas. Okay. Moving on to the next question. Now, a patient shows pruritus, elevated ALP and AMA positivity. MRCP shows normal appearing large bile ducts with no strictures or beading. HPE is shown below. What is the diagnosis? Now, pruritus and elevated ALP, both of them suggest us of a cholestatic disease, right? This PBC AMA positivity suggests us of PBC. Okay. And this MRCP showing a normal appearing bile duct with no strictures or beading helps us to rule out PSC. Remember that in PSC, MRCP shows strictures and beading, right? So we ruled out PSC, and AMA positivity is also suggestive of PBC, and we have a histology over here, and this is our florid duct lesion. What is that? It is a periductal infiltration. We can see the infiltration over here. We can see the periductal inflammatory infiltrates, right? Moreover, we can also see a granuloma over here. Which is rather non-caseating, granuloma. So florid duct lesion, that is periductular inflammation, along with non-caseating granuloma, is very much suggestive of PBC. So over here the diagnosis is without any doubt PBC. Okay. Early PSC, it has been ruled out, right? We would have got strictures and beading and MRCP. Secondary sclerosing cholangitis, secondary sclerosing, as the name suggests, would be due to secondary causes in the form of like stones, infection, or even ischemia. Okay. Caroli's disease, we would get a different MRCP pattern. In MRCP, we would get cystic dilatation. And we call that, and we also get a sign called the central dot sign. We get a central dot sign, right? So over here, the answer would be PBC. Moving on to the next question. Which complications are more commonly associated with PBC? Complications of PBC. Osteoporosis. Yes, we would get osteoporosis because of cholestasis. There would be decreased absorption of the fat soluble vitamins, decreased vitamin D. That's why we would get osteoporosis. Fat soluble vitamin deficiency. Yes, all A, D, E, K, everything would be low, right? Inflammatory bowel disease. No, inflammatory bowel disease is a PSC association, right? It's associated with primary sclerosing cholangitis. Hepatocellular carcinoma. Yes, remember that PBC progresses, right? Intrahepatic cholestasis, it progresses and can progress to cirrhosis. It can trigger cirrhosis, and cirrhosis can also progress to hepatocellular carcinoma in PBC. Okay. So answer over here would become A, B, and D. Okay. Moving on to the besides these complications, we can also get hepatomegaly. We can also get steatoria. Right, because of fat malabsorption, right, and that can result in weight loss. Okay. Moving on to the next question. The first line treatment for PBC. Remember, the first line treatment for PBC is ursodeoxycholic acid. This ursodeoxycholic acid decreases our ALP levels as well as bilirubin levels. Besides that, it also slows down disease progression, and it also increases transplant-free survival period, right? It also increases the transplant-free survival, right? That's why it is the first line. If we talk about the other option, obeticholic acid, it is the second line drug. Right? It is used when we get inadequate response to ursodeoxycholic acid. Okay. And if we talk about the other two, prednisolone and azathioprine, they are actually used in autoimmune hepatitis, not used in PBC. Okay. Moving on to the next question. Which diseases are strongly associated with PSC? Now, associated with PSC, we all know that PSC is associated with inflammatory bowel disease. Without a doubt, A and B would be our association, and among these two, ulcerative colitis is much more common than that of Crohn's disease. Talking about autoimmune hepatitis, it is not associated. Rather, autoimmune hepatitis is associated with PBC, biliary cholangitis, right? And we also get a symptom, and we also get a overlap syndrome of PBC AIH. There can be a overlap syndrome with these two, diseases, right? And IgG4 disease, yes, this is also associated with PSC. So our answer would be A, B, and D. Okay. Moving on to the next question. A 30-year-old male patient presents with episodes of right upper quadrant pain, jaundice, and fever. Lab shows elevated ALP, and this MRCP finding is shown in the image. What is the likely diagnosis? So we get a 30-year-old male, and we have right upper quadrant pain, jaundice, and fever. These three things are Charcot striatum. These three things form our Charcot striatum, and Charcot striatum is seen in acute cholangitis. Okay. A 30-year, a middle-aged man with, and this elevated ES shows us a middle-aged man. He is a middle-aged man, and elevated ALP shows us cholestasis, features of cholestasis. So a middle-aged man, cholestasis, along with this acute cholangitis picture, right? Then we have this MRCP finding where we get this beading, of both intra and extrahepatic bile ducts, right? Everything over here suggests a diagnosis of PSC. Everything, right? PSC, one of the most common presentation is cholangitis, right? In PSC we get cholangitis presentation, but in PBC we do not get a presentation like cholangitis, right? So cholestasis along with the presenting features of acute cholangitis in a middle-aged man with MRCP showing beading of intra and extrahepatic bile ducts, our diagnosis would be without a doubt PSC. Why not acute cholangitis? This Charcot striatum can be seen in acute cholangitis as well. Acute cholangitis could have been a direct answer, but over here MRCP wouldn't have shown beading. MRCP would have shown obstructive features. Okay. In PBC we would have got normal MRCP, and again in Caroli's disease, central dot sign as already discussed. We would get central dot sign, right? Cystic dilatation. We would get cystic dilatation in Caroli's disease. Okay. Moving on to the next question. Which antibody is most frequently associated with PSC? Already discussed, it would be P-ANCA. AMA is associated with PBC. ANA is associated with both PBC and PSC. PSC can be positive in, ANA can be positive in PSC as well. But P-ANCA is a better choice. If we talk about this anti-LKM one, it is associated with type 2 autoimmune hepatitis, right? This anti-LKM antibodies are quite common. If we talk about this liver kidney microsomal antibody, if we talk about anti-LKM1 antibody, they are present in they are positive in type 2 autoimmune hepatitis and and chronic hep C. If we talk about anti-LKM2, it is present in drug-induced hepatitis. And if we talk about anti-LKM3, they are present in chronic hep D. Right, just factual note. So moving on to the next question. A 32-year-old man presents with fatigue and features of cholangitis. Right. Now, histology of the biliary tract is shown. Which of the following statements about the diagnosis is incorrect? So again, a middle-aged man, we get a middle-aged man, we get fatigue as well as cholangitis, and in the histology, we see this onion skin periductal fibrosis. Right? Everything over here is suggestive of a diagnosis of PSC, right? We get florid duct lesion in PBC, whereas we get this onion skin periductal fibrosis in PSC. So diagnosis is PSC. Which of the following statement is incorrect? Let's have a look. Ursodeoxycholic acid helps to slow down the progression of the disease. This is our false statement. Remember that ursodeoxycholic acid slow down progression in PBC, right? But not in PSC. We might prescribe this. We might prescribe it in PSC just for symptomatic management, but it will never decrease or slow down the progression of the disease. It will progress to end stage liver disease. Males are affected more than females. That's a true statement. Over here, the male to female ratio is around 2:1. Associated with ulcerative colitis, yes. And associated with HLA, B8 and DR3, that's also a true statement. So over here, our answer would be A. Okay. Moving on to the next question. Which of the following complications are significantly increased in PSC? Okay. Cholangiocarcinoma, yes. Gallbladder carcinoma, that's also a true statement. Ulcerative colitis flare, no, this is not increased in PSC as a complication. Remember that ulcerative colitis is associated with PSC, but PSC does not result in flare up of ulcerative colitic lesion. Okay. So this is our incorrect one. And colon cancer, yes, it does increase the risk of colon cancer. So our answer would be A, B and D over here. A factual question, but remember the fact that it does not increase the risk of flares of ulcerative colitis. Okay. Moving on to the next question. What is the only definitive treatment for advanced PSC? If we talk about definitive treatment for PSC, we all know that PSC, even with medical treatment, it will progress to end stage liver disease. So the definitive treatment has to be liver transplantation. Remember that ursodeoxycholic acid and obeticholic acid are used in PBC, right? Ursodeoxycholic acid can also be used in PSC, but just for symptomatic relief, not for slowing down progression, not for treatment. Not for curative purpose. And ERCP dilatation is actually a palliative measure. That can be done for strictures. Okay. Moving on to the next question. Which of the following features of PBC and PSC are true? Right. Before reading the options, let's quickly have a comparative study between PBC and PSC. Right. Remember that in PBC only intrahepatic ducts are involved, whereas over here in PSC intra plus extrahepatic ducts will be involved. Both of them will be involved. If we talk about smoking, risk as a smoking, we already discussed that in our first question. Smoking increases the risk in PBC, whereas it decreases the risk in PSC. Okay. If we talk about associations, in PBC it is associated with Sjogren syndrome, whereas in PSC is associated with IBD. Right? In IBD, you see much more than that of CD. Okay. If we talk about the gender predisposition, females are affected much more than males in PBC, whereas males are affected more than females in PSC. Okay. If we talk about the antibodies, it is AMA positivity most commonly. Can be ANA positive as well. Over here it is P-ANCA positive. And sometimes rarely ANA positivity can also be seen. If we talk about the biopsy finding, we get a florid duct lesion, which is nothing but a periductal inflammation, florid duct lesion with non-caginating granuloma, whereas over here we get onion skin fibrosis, periductal fibrosis. And if we talk about management, over here ursodeoxycholic acid, obeticholic acid plays some role, as over here we would require liver transplantation. Right. because it will anyhow progress to end stage liver disease. This is the basic difference that we need to remember between PBC and PSC. Right, let's have a look into the options. PSC affects the small intrahepatic ducts only. That's a false statement. It involves both of them. Smoking increases the risk of PSC. That's a false statement. Smoking increases the risk of PBC and decreases the risk of PSC. PBC is strongly associated with UC. No, PBC is associated with Sjogren, and PSC is very strongly associated with UC. And AM is strongly positive in PBC. That's a true statement. So our answer would be only D. Okay. Moving on to the next question. A 35-year-old man with PSC undergoes ERCP for biliary stricture dilatation. Now 6 months later, he developed worsening jaundice, weight loss, and his CA19-9 is elevated. What is the most likely diagnosis? Now this worsening jaundice, weight loss, as well as increase in CA19-9, everything over here suggests us of malignancy. Right. So we can easily rule out option C and option D. It can never be liver abscess. It can never be recurrent PSC flare. Now we need to differentiate between HCC and cholangiocarcinoma. Remember that in both of them there would be weight loss, and both of them there would be worsening jaundice. Both of them are associated with PSC, and both of them have increased CA19-9. So again, we cannot differentiate between these two with the given information. So the most likely diagnosis would be based on incidence. Remember it as a fact that cholangiocarcinoma is much more common than that of hepatocellular carcinoma as a complication of PSC. So over here our answer would be B, cholangiocarcinoma. Okay. Had cholangiocarcinoma been not there in the option, then HCC would have been our answer, right? But if both of them are present, then cholangiocarcinoma has to be our answer. Okay. With this, we come to the end of our discussion on PBC and PSC. Right. If you like this video, consider subscribing to my channel, and thank you for watching.